surgeons here, trauma and general surgery, and the director of global surgery. And we have Dr. Karol Budohoski, who is our guest speaker for today, who is newish faculty, and the Department of Neurosurgery, and has also runs a research lab here and is very interested in how do you build capacity, especially for stroke and traumatic brain injury care around the world. He's going to talk a little bit about some of his experience in Tanzania. So welcome and thank you so much.
Thank you very much, Suha. Thank you guys for having me. So that's all very true. So I'm a neurosurgeon. I'm a fairly new faculty here. It's my starting my second year. And my main thing is, my main subspecialty is vascular neurosurgery, but I've been involved in global neurosurgery for quite some time now, and mainly started my work looking at neurotrauma and spine trauma as I was still a resident, but I've transitioning to doing a little bit more of something which is a bit more in line with what I currently do as faculty here, which is, vascular neurosurgery, and part of that is stroke thrombectomy. So we'll talk a little bit about trying to establish or things about establishing a thrombectomy service in a resource-limited setting, in particularly in Tanzania. But just as a brief overview, we'll talk a little bit about the definitions of what stroke actually is and what the epidemiology of stroke is, what are the current management options, some of the worldwide stroke care, and then specifically the Tanzania stroke projects. And I'll try to make it in a way that maybe you'll understand why we're talking about stroke in a global surgery center discussion. So just very briefly, for those of you who don't know, a stroke is a focal onset of a neurological deficit that lasts more than 24 hours and is not traumatic in cause, right? And the reason it is said to last more than 24 hours because everything that's shorter than that is called a TIA, and it doesn't leave a residual on a DWI MRI scan. And there are basically three types of stroke. There's subarachnoid hemorrhage and intracerebral hemorrhage, which are also hemorrhagic strokes. And then there is ischemic stroke. And today we'll very much focus on ischemic stroke, which constitutes by and large the bulk of strokes in general. It's 85% of strokes, with the rest being a very small subpopulation, although very devastating in their nature, but the treatment of which is completely different. And a very few words on the epidemiology of stroke. And we don't have great studies about worldwide epidemiology of stroke, but we have pretty good studies. But some of the stuff that we'll talk about comes as an extrapolation of things that has been studied in the US by the CDC or in Europe or Australasia. But we generally know that stroke is one of the leading causes of death in the US and worldwide, and it's probably the #1 cause of disability because it leaves such a lasting impact. So in the US, we think that there's about 800,000 strokes that happen every year. In the world, it's going to be obviously considerably more, which means that there's a stroke that happens every 40 seconds, and then there is a death from a stroke that happens every 4 minutes. So it's a very, very significant problem. Not all of these strokes are strokes that we can treat in a way that I can treat them from a endovascular perspective, but some are. There's obviously a very large proportion of those, like we talk about the 80% that can be prevented, which by and large would be the best thing ever, right? If you can not have a stroke at all, then that's better than having a stroke and having it treated by anyone. And then there's an association called the World Stroke Organization that tries to track strokes around the world and tries to give an overview of what the epidemiology is and tries to establish guidelines of how to treat stroke around the world. And so we just talked about the US, but if you look at the world, there's about 12 million strokes happening every year, and there's about 100 million people living with stroke at the moment. And you can see, this is all very a nice little pictograph, but you can see that the amount of, or the number of people living with a stroke has doubled over the last 30 years, right? So there were 50 million people in the 1990s, there's about 100 million people now. Some of that means that there's just people are surviving longer, the population is aging, older people get more strokes, but also just the incidence of stroke is getting higher. And importantly, we all think that it's like this disease of the elderly that, you know, you're 150 years old and so you'll get a stroke and that's it. But actually, almost 2/3 worldwide of strokes happen in people who are less than 70-year-old. In the US, it's slightly less, about 34% of people with a stroke are less than 65. But still, it's not just the disease of the elderly. And if you think, you know, 2/3 of that 100 million is actually quite a substantial number of people who are less than 70 who are living with consequences of a stroke. And there's been a lot of work throughout these last few decades, but certainly recently on the global burden of disease. And those studies were commissioned by the Lancet by and large and published in the last few years in terms of the updates from the last maybe 20, 30 years. And some of those studies also involve stroke. There's lots of studies about trauma and surgery and all these sorts of things, but also about stroke. And this is a great study to just take a look at to just get a gauge of the statistics that are available out there. It's been published in 2021. And the bottom line is the absolute numbers of strokes are increasing significantly. You can see they haven't quite doubled, but they've almost doubled since 1990 as well. And that just is the consequence of what I've just showed you before in that pictograph. Some of that means that the population is getting bigger, and so there's more people, and so there's more strokes. But generally speaking, the incidence is certainly increasing. And with the incidence, the death rates are increasing because there's more stroke, more people are getting stroke. We're not necessarily that much better in treating stroke, and so more people are dying. And certainly we're losing more what we call DALYs, or the disability adjusted life years, right? So it's a significant contributor to these life years lost. And then these studies from the Lancet, they give a very nice overview of the maps of where the burden of diseases are. And, you know, most studies about stroke come from the US, Europe, Japan, these sorts of places. But actually, when you look at, so this is a map that shows the incidence per 100,000 people. And the more blue it is, the less the incidence, the more red it is, the higher the incidence. And you can see that it's very much skewed towards, you know, parts of Latin America, Africa, both northern, sub-Saharan Africa, as well as Asia and sort of Far Asia, and then obviously a bit of Russia here. And you can see that it's very much skewed to what we call the global south, or the non-Western world, or whatever you want to call it, but to the very developing societies. And when you look at the DALYs lost, it's exactly the same, right? So it's not that the burden of disease is in the US, or it's in Europe, or it's in Australia, but actually the burden of disease and the quality of life lost, and the economic impact is very much skewed towards those same regions. And also when you look at what's been happening in the last decade, so these are the high income countries. You can see the incidence or the age standardized rates of stroke are significantly down over since 1990. Whereas if you look at the low and middle income countries, they haven't really done that. There is been a bit of an improvement in the first in the last decade of the 90s and maybe in the beginning of 2000s, but it's largely normalized now and it's very static. And so even those age standardized numbers aren't really changing that much in the last, say, 20 years. And I think this is one of those like most important, most compelling things that you see, that we sort of I gave a talk here about trauma before and traumatic brain injury, and there's always this concordance that like 85% of literature on TBI comes from the US, Europe, Japan, Australia maybe, whereas 85% of actual TBI happens not in those countries, right? In the lower and middle income countries, that's where the burden of disease is. And clearly it's exactly the same here. So you can see 86% of deaths from stroke happen in LMICs, and 89% of DALYs lost happen in LMICs. So it's significantly affecting the lower and middle income countries. Now, I think some of that is probably skewed by China, which obviously is a huge country. I don't know whether you can really consider it in that same bracket as, you know, lower and middle income countries, but still, there's a vast population in Africa, vast population in, you know, Far East Asia, vast populations in Latin America, where all of these things happen, and the treatment is not that developed. And so I'll quickly talk about what the treatment is for stroke. And so if you look at it historically, up until the 1990s, there was pretty much nothing, right? You had a stroke and you went to a form of rehab that I guess was there in the 1990s. And then in the sort of early 90s and culminating in the NINDS trial, TPA came on board. And so that was like a game changer. This was the first drug that ever was proven to be of any benefit in a stroke. But there was a big caveat. There was a 3-hour window. And so that meant that even if you're in the best place ever, you're still very unlikely to be eligible to have that treatment, because for you to come within 3 hours and have your scans and have all the assessments and get the TPA was not very likely. And so then there was another trial in 2008 that established that 4.5-hour window, which we sort of know now. But you can even see here that, you know, that the progress for stroke is not really fast, right? So like from 1995 to 2008, they've managed to improve the whole thing by 1.5 hours for the same medication. So it's a pretty slow moving thing. And that just sort of exemplifies how difficult it was always to treat stroke. And for most of like my medical education, the treatment for stroke was pretty much rehab or TPA and nothing much apart from that. And then when people looked at the different versions or different types of strokes, obviously we're all talking about ischemic stroke here, but within ischemic stroke, there are different types of stroke. And when we talk about large vessel occlusion stroke, which is that sort of most devastating form of stroke where a big chunk of brain gets injured from ischemia, it sort of is about 25 to 33, so like 1/4 to 1/3 of all strokes, so not an insignificant amount, not the majority, but still not an insignificant amount. And the results for that, for TPA, are much worse than the results for the small vessels. And it's just a factor of the fact that the vessel is big, so the clot is big, and so dissolving that clot with any lytic medication is going to be more challenging than with a small clot in a small vessel. And then the favorable outcome rates are also much worse for these. And so people have been sort of pondering about how to treat those differently than using TPA for a long, long time. And I guess this is the first mechanical thrombectomy publication that I know of, and that was in 2002. And so people have been thinking, can we just like, these are big vessels, right? We don't need a drug. Can we just like shove something up there and pull it out, pull that clot out? And so that first mechanical thrombectomy that was published was in 2002. You can see that there's an occlusion probably somewhere distal to the ICA here. And they effectively used, we call it a cordless catheter, which is just a big tube. It's like a big aspiration catheter that they use in body IR and cardiac. And they shoved it up there, took a big 60cc syringe, pulled it onto aspiration, and then pulled the whole thing out and managed to revascularize the vessel. You can see that the vessel is sort of a bit funky here. It's not really healthy because of what they've done to it, because it was a fairly aggressive treatment. But it worked, and it was published in 2002. And then since then, that technique has evolved, and lots of people have been trying mechanical thrombectomy for many, many, many years. And they sort of developed these slightly better stent retrievers where you would put like a little corkscrew into the clot and try to pull that out. Then there were different aspiration catheters, and then there was what we sort of use now, which are called stent retrievers, which is a bit like a stent that you deploy in a vessel and pull that out. And then they developed these very sort of directional aspiration catheter that you can actually bring up very high up onto the clot, and you know, using manual or aspiration, you can suction out the clot, and there are combinations of the two. And that led to significant improvements in the technique. But along the way, there have been trials that were all negative, right? They did trials of mechanical thrombectomy, and one trial after the other failed, and they didn't show outcome benefits, and they showed lots of hemorrhages. But people sort of persevered because you could see some of those patients where you would put a catheter and open up the vessel, and a few of them did really well. So people sort of thought maybe it's the technique, maybe it's the technology, that's not quite right. And then finally, in 2015, there were these 5 trials, all published sort of at the same time. Some of them stopped short because the first one was published, but by and large, all of these 5 trials showed a significant benefit of mechanical thrombectomy, right? So they showed that there's, and again, these outcomes are phenomenal, right? You can see 33% versus 90%. They're poor outcomes still because these patients do poorly. But by and large, they showed improved outcomes in patients who receive mechanical thrombectomy. And so then this was published as a meta-analysis, and they showed that the number needed to treat was 2.6, which was sort of phenomenal in the field of medicine. I don't know, like to me, always like PCI and cardiac interventions were one of those things that we would benchmark against. And I think their number needed to treat is close to like 13 or 16 or something. So it was really beneficial, really game-changing treatment. And so that quickly led to change in the guidelines. And so in the US, the American guidelines have come out with, thrombectomy being the gold standard of treatment for anybody who's within 6 hours. So that was pretty good, much better than 4.5 hours, but still not great. And then subsequently, they did some more trials, and they looked at extending that window to 18 hours and then subsequently to 24 hours. All of them were positive. And so now with a few caveats, so you have to have a decent stroke, NIH of above 6. So that means you do have significant symptoms. We don't do this in patients who are pretty well, with a bit of numbness or something. You have to have an aspect score, which is high at the moment in terms of the guideline. Aspect is a very crude way to measure how much hypodensity there is on a CT. So if you come and you have the whole hemisphere hypodense, which looks like a stroke, then you're probably not going to benefit. But if it's only bits in the areas, then you may benefit. And then you obviously need an occlusion in the M1 or ICA. And then for the delayed studies, for the delayed windows, we talk about CT perfusion and the core of infarct versus whatever tissue there is at risk. And then I don't want to sort of get into the very details, but subsequently there's more trials that are coming out with big infarcts and pretty much everything you throw at this, people get benefit. So obviously, the quicker you come, the less infarct you have, the better you'll do if you have a successful thrombectomy. But even in people who are elderly, have big infarcts, come late, don't have much penumbra or the sort of tissue at risk, they still do better. And so this has pretty much come into like the gold standard of treatment. And since 2015, people get thrombectomy as the primary treatment. And it's the most important part of it in terms of the eligibility of people is that or pretty much 0 to 24-hour period where people can still be enrolled in those treatments. People can still get those treatments, which is a significant benefit over the 4.5 hours. That we had for TPA. And the reason this is important for me is because establishing a treatment service in a low resource setting, one of the very difficulties for any emergency treatment is that time window where people get to hospital, when they get investigations and when they can get treatment. And 4.5 hours is very difficult here. It's much more difficult in a place like Tanzania, just because the resources are a little bit less available. So how does it look now? So we talk about this great treatment. It's been 2015, so it's now almost 10 years, not quite. In the US or in Utah, everybody who comes in is eligible gets it, but how does it actually pan out around the world? And it turns out that the treatment for stroke around the world is very poor, right? That there's very few people who are eligible who get that sort of treatment, whether that's TPA or whether that's mechanical thrombectomy, whether that's even rehab, right? And so there's been this great study called Empty Glass. And again, I encourage you, whoever's interested in stroke, to take a look at that. But this is a study that's come out of a group of people who established this sort of like call to action thing called Mission Thrombectomy 2020, which is effectively a group of people who do thrombectomies for stroke. And they're trying to sort of expand it to places around the world, which may not have as easy access to that. And so they surveyed 63 countries. These are the countries that they surveyed. And, this is a pretty good effort, right? You can see there's lots of gray spots around here that they didn't have any data on, but still this is a pretty good effort. They've captured lots of places in, Africa, Asia, Latin America. So it's a very good spread. And what they effectively showed is that the eligibility or the people who end up getting mechanical thrombectomy very much differs between the high-income countries, where it's still only 20% of patients who would otherwise be eligible, to low-income countries, where it's pretty much 0. And then the upper middle, income countries, they have between 2 to 3% of people who are eligible get the treatment, right? So in a quarter of countries that they surveyed out of the 67, less than 1% of eligible patients get mechanical thrombectomy. And in 10% of the countries, 0% of patients get mechanical thrombectomy. Right? So it just shows that it's a very difficult thing to introduce in a way that there's a lot of things that need to fall in place to try to pick up that one patient that will benefit from mechanical thrombectomy and actually get it done. And we're going to be talking about Tanzania, so we'll sort of try to narrow down to what's happening in Africa. So this is another good study that looked at access to stroke it was sort of called Sub-Saharan Africa, but obviously there are places here which are sort of Northern Africa. But they looked at 17 countries and they sort of found that out of those 17 countries, only 2 had a stroke center being defined as a place that can provide all of these treatments. And then 5 of these countries had a stroke unit. A stroke unit was sort of defined in a slightly vague way that it's not quite the same as a stroke center, right? And then, quite a number of countries had the availability to give TPA. And then 6 out of those countries, so 30%, had the possibility of doing mechanical thrombectomy, but only actually 5% of patients received either TPA or mechanical thrombectomy. The reason these numbers are probably the same is for that window reason, right? So you can be capable of giving TPA, you may have TPA in your pharmacy, but in sub-Saharan Africa, for instance, you also rely on the fact that the patient needs to get to the hospital in time, and they need to get a scan in time. And the pharmacy needs to be available and open in time. And sometimes they need to pay for the medication even in time, right? And so it's not so easy to get that patient treated within that period. And then we'll try to focus a little bit on Tanzania. So Tanzania is a sub-Saharan country in East Africa, right? It's sort of bordered by the sea and then bordered by Lake Victoria on the other side. It's actually quite a large country. About 60 million people live in Tanzania. It's not one of few, but it's one of not that many countries in sub-Saharan Africa where there is a little bit of data about epidemiology of stroke. And there's quite a few pretty good publications about stroke in rural and urban Tanzania and stroke in elderly people and younger people in Tanzania. But the gist of it is that, there's about 100 strokes per 100,000 people in in urban Tanzania, and then just a little bit less in rural Tanzania, which falls into that sort of reddish part on the map that I showed you before. There's quite a lot of people who are young who get a stroke, there's certainly much more of it than there is in high-income countries. So this was the first study that sort of established a little bit of the burden of disease. This again is all strokes, so not only ones that we can treat with mechanical thrombectomy, but all strokes. And then there's been some more studies that show that the outcomes for all of these strokes is not great, expectedly, right? There's mortality is about 40% in the first year, and there's another 40% of unfavorable outcome rate. So pretty much 80% either die or have a poor outcome. And in that study, I think pretty much nobody returned to work. And that's a factor of some of the economy of Tanzania, right? There's a lot of that work is farming and subsistence farming and things like that. And so if you had a stroke and you have a disability, it may be very difficult to do that. But it's also a factor of the lack of the post-stroke care, right? Like things like rehabilitation. And so although a lot of improvement just happens on its own, a lot of it does require significant rehab and significant resources to be put into rehab. And so the outcomes of having a stroke in an area like that are pretty devastating, right? Especially if you're the breadwinner for the family, for instance, and you're not going to go back. And there's been a little bit of work trying to figure out what is the epidemiology of patients with what we call an LVO, so a large vessel occlusion, which would be eligible for a thrombectomy. Now, the problem with all of these studies that have been done so far is that they rely on registries and whatever imaging is available. And so this is a sort of extrapolation. So this data is an extrapolation of people who had a CT scan in a delayed fashion that showed a large infarct, which would be most likely caused by a large vessel being occluded, but it doesn't take into account whether any of these patients would have been eligible to have treatment because they would have come in the right time or didn't have a bleed or something like that because they just didn't get the scans in time. And so it's similar to what we've said, right? So 40% of strokes in the Tanzanian setting are large vessel occlusions. Of those patients, I think the median time to arrival to hospital was about 2 days. So most of these patients wouldn't have been eligible. But they're not old, the median age was 60 years old. And the outcomes was pretty bad, right? So 60%, close to 60% of patients with an LVO would have died within the 30 days, which pretty much means they would have died in hospital. And then 75% would have died within the first year, right? So again, that does place into context the fact that even if you survive the initial injury, then there's lots of things that can go wrong afterwards, right? If you don't have rehab, you lay in bed for long, you get DVT, you get pneumonia, you get all sorts of problems, you get ulcers that then end up taking your life with the absence of the sort of post-stroke care. And there is a great database that there is a few people who have established a neurology service in Tanzania, and it's sort of grown to be a bit bigger in the recent times, and they're sort of working on trying to establish stroke centers and stroke units. And so there's a very prolific girl whose name is Sarah Matuja, who's a neurology fellow at the Muhimbili National Hospital in Dar es Salaam, and she's started a lot of the work and some of the studies that I published, that I presented, she's led or she's participated in a significant way. And she's effectively collecting data of all the stroke patients that are coming through. And you can see that, she's got, this is until October 2022, she's collected about close to 600 patients with stroke, looking at their outcomes. And so it's a really nice way to figure out the epidemiology, figure out what are the risk factors, what are the things that are being done, what are the currently available treatments. And for somebody like me, it's really nice because it really facilitates trying to plug myself into that already existing infrastructure to see if we can look at a few other things that may be of also of benefit. And so the one thing that she's shown is, if you look at the TPA eligible patients, there's only 5.5% that would be eligible for TPA of all the strokes that come. And that's primarily because they just don't come to hospital in time or get imaging. When you look at thrombectomy, it's close to 20%, which is not great, but it's still much better than the 5.5%. And so when we started talking with her about mechanical thrombectomy, it seemed like an idea that the whole of the neurology team there was really much on board, because they really struggle with patients coming in late or patients getting their imaging late, because even though they have access to TPA, they just don't have the patients to give it to. So this is really nice to have that sort of infrastructure that's been already developed to be able to know some of these things. But I guess, you can always ask this question, why would you do mechanical thrombectomy? And I'm obviously preaching here to the converted, but why would you do mechanical thrombectomy in resource limited setting if there is no rehab, right? If we're struggling with water sanitation, or we don't have anesthesia, or there's lots of things. But these are the same questions that occur when we talk about surgery, right? What would be doing surgery in a resource limited setting? And that's been sort of the mantra for many, many years, right? People would focus on malaria, TB, communicable diseases, these sorts of things, sanitation, before they focused on surgery. And then obviously you all know this, right? But these are that publication of the Lancet Commission of Global Surgery 2030 that showed that there's this vast amount of unmet need in terms of treating patients that have surgical needs. And we talked about this before, right? There's like the 5 billion population of people who don't have access to safe and affordable surgery, right? There's 143 million additional surgical procedures that are needed. And what I want to try to hone in is the fact that mechanical thrombectomy, although it's not surgery and it was not included in this, is sort of like surgery in terms of what it needs and what the infrastructure needs are, and what actually the outcomes of that untreated disease versus treated disease may be. And a lot of the things that they recommend in that Lancet Commission would really be the same for establishing a stroke service. So we've sort of been using that as a blueprint in terms of trying to figure that out, right? And we know these data that there is close to 17 million lives lost in 2010 alone due to not treated surgical conditions, which dwarfs all those infectious diseases that we typically focus on. But if you add all the stroke to that, then that becomes even higher. And the stroke itself is almost probably half of that. And again, this comes from the Lancet Commission, and it sort of explains what a difficult setup is required to provide surgical service for any condition, really. But those same services are needed for stroke in almost a more difficult way, right? Because the community and the primary health in terms of getting patients is almost non-existent or non-influential, and it's only the emergency services that you need, which you think may be easy, but actually it's not, because it means ambulances and 911 and call centers and all these sorts of things to try to get people to hospital early. Whereas that's often not available in many places around the world, and people have to make their own way to hospital, which sometimes is really eligible. And then obviously there is the whole back and forth between the treatment and the rehabilitation that again is really required for any patient with a stroke. And so just going back to that, this is why we really need it, right? Because there's so much burden of disease in low resource settings that it just needs to be addressed in some way. And then the final thing I just wanted to say, this obviously comes from the US, and these are data from Mission Thrombectomy that I showed you. But one of the big problems with surgery and with thrombectomy and with any endovascular work that I take part in is that it's very, very expensive to do. And in thrombectomy, there are many things that are expensive. There's, getting the patient to the hospital requires an ambulance, that's expensive. Getting them imaging oftentimes is very expensive. Certainly performing the procedure with all these disposable equipment is very, very expensive. And so a disease treated with mechanical thrombectomy for that one person on that one day is much more expensive than the same disease treating with just natural history, right? Because if you treat it with natural history, the patient goes into a bed and they don't require any of those expensive bits of equipment. At least in the US, those studies aren't done and are not available in places like Tanzania. But in the US, over the lifetime, it does save $23,000 per patient, right? So if you do 10 patients, it's $230,000. If you do 100, it sort of accumulates like that. This obviously may not be necessarily true for low resource settings because some of the costs may be cheaper, but also some of the benefits may not be as big because of other things such as rehab, for instance. But there's generally a benefit of cost savings for patients with mechanical thrombectomy. In the US, it's after 9 days, and then obviously this is the lifetime risk. In other places around the world, that benefit manifests after a year or 5 years, but it always does manifest. And so, like I've showed this before, but for me, the beginning of sort of working this was in 2008. I was like a final year medical student. I went to Kenya, worked in a place called Kibera, which is a slum next to Kenya. And I really liked working there. And it was just like a pleasant experience for me. But you also saw that there's a big need. And for many years, I tried to figure out how do I plug myself into doing this a bit more long term. And I was very fortunate, and I met these two guys. One of them is Roger. This is a neurosurgeon. He's a critical care doctor. They both work in Cornell, and they introduced me to the Tanzania Neurosurgery project, where they set up this course after many years of working in Tanzania and working together with the neurosurgeons at the Muhimbili Orthopedic Institute in Dar es Salaam. And they sort of introduced me to that, and I was really fortunate to be able to go with them to many of these courses and teach on some of them and sort of learn myself, really. And I was doing this for a very long time, focusing on neurotrauma and spine trauma, but I was sort of really trying to figure out how do I plug my expertise in to this global neurosurgery platform. And being a vascular neurosurgeon, it's even a little bit bespoke here, and so it's not necessarily where the need is until those development of stroke, where actually there's a significant need and a significant benefit. And when I visited Dar es Salaam, you see the hospital and the floors and the operating rooms and things like that, and you sort of see that there's a definite need and there's definite resources that are needed, and it certainly is daunting in a way, but also makes you really want to try to help and try to plug yourself into doing that. And so this is where the Tanzania Stroke Project sort of arose from. And, you can even see that the name is very similar to that Tanzania Neurosurgery Project, because I was sort of trying to model it on what they've been doing since, I don't know, probably now a decade. And we were thinking about how to address, and we sort of talked with the neurologists in Dar es Salaam and talked to the neurosurgeons in Dar es Salaam and tried to figure out how do we go about tackling this problem in terms of trying to see if mechanical thrombectomy could be available in Dar es Salaam in a few years. And then the first thing that obviously came to mind is that we need to establish the epidemiology, because the epidemiology is always really important because it tells us how many people would be eligible for this. If it's one person a year, then obviously there's no point. Um, so it gives us that, but it also gives us a bit of an idea of what resources would be necessary, right? Because there's one thing about coming and bringing some things and doing a few procedures, but generally, if we want it to be a long-lasting thing, we need to know whether we'll, there'll be 50 patients that will be eligible for treatment and how much that would cost. And so that gives fuel to discussing with the managers of the hospital, the director of the hospital, to say, look, this is what it's going to cost to provide this sort of service, but ultimately this will be of benefit to you. And in Tanzania, it was a great time because I think people are starting to realize, and it's a little bit like everywhere else in the world, right? People at high levels of society are starting to realize that, if you're in Tanzania, even if you're the son of the president and you suddenly get a stroke, because it's such an acute disease, nothing will help you, and it's just going to be natural history. And so when people in those sort of positions of power realize that, then it's a nice time to try to persuade them that maybe we could provide treatment for that. And there's a very good blueprint for that, because there was a very prolific cardiologist in Tanzania who's done a very similar work in establishing cardiac care for PCI for patients with heart attacks and STEMIs in Tanzania, and it's been working for many years now, and it's a really good service. And so we've been trying to pick his brain a lot. But so we want to define the true epidemiology of those patients with mechanical thrombectomy. We want to figure out what are the essential services that are required to do a thrombectomy, right? And there's a very big difference between being in a center such as here, for instance, where you have sort of access to most of the top technology that's available, which is really expensive. But what we're trying to figure out is what's actually required, right? We don't necessarily have to have the Cadillac of angio suites and all the fancy equipment. We need to have something that will do the job well and safe, but it doesn't need to be the latest technology, which is going to be much more expensive. So we're trying to figure that out. One of the biggest difficulties I have is how to identify the people who would be most suited to learn this technique and do it. And this is difficult because it's a slightly weird technique at the intersection between multiple specialties, right? So there are people who are body radiologists who have catheter skills, but they don't really necessarily know much about the brain. And then there are people such as neurosurgeons or neurologists who don't have catheter skills, but they know a lot about the brain. And so we're trying to figure out who would be the best person to train. And it may be that in the short term, it will be somebody different than it will be in the long term. And then developing those sustainable models of education is sort of goes hand in hand with that, which is very difficult from a place like Utah, where I'm just not physically there, for instance. And then we're trying to do a global study looking at outcomes of LDOs with and without mechanical thrombectomy, as a mimic to a study that we've done before. And so defining the epidemiology we were really fortunate. This is the lady that I told you about. This is Dr. Matuja, who's a neurology fellow who's established a stroke registry. We're sort of working with her now, and she's really the engine behind this, and she really wants to get these things off the ground, and she's a phenomenal partner to have. And we're trying to organize some funding that will now be able to provide rapid access to imaging just for everybody who comes with a syndrome of a stroke, so that we can actually see. So if we had the money and if we had the CT angiogram, how many of those patients would be eligible? So how many people come within 24 hours, have a decent amount of stroke, but also decent amount of brain to save, and have a large vessel occlusion. So she's hopefully going to really push this project along. And then we talked about this in brief. We're trying to define these essential services that are required. And this is important because if we do that, we're going to be able to also advise on what's required in the hospital infrastructure, right? We'll be able to, or not only me, but like Dr. Matuja or the neurosurgeons or the body radiologists who are really there on the ground and they have access to the directors of the hospital, they're going to be able to say, well, we need this sort of angio machine. We don't need that $300,000 one. We can do it. This one is going to be great, right? Or we can do it on the angio suite that we have for the cardiologist, for instance. And we don't have that many patients, and we're not going to occupy it forever, but we'll do it that way. And also, figure out whether we need anesthesia available all the time, or maybe we can do it with just sedation, or whether we need a biplane machine or a single plane. We talked about those stent retrievers. A lot of people now in the US do these thrombectomies with just an aspiration catheter, which cuts the cost probably in half of the whole procedure. And so whether that's, that's a good substitute, and that's a good way of just going forward so that we have something. And some of those studies have been done, right? So we know that you can often skip imaging. So this is obviously a study that was done for different reasons. It comes from Europe, but they looked at whether you can have a clinical syndrome, a CT scan that shows no hemorrhage, if you can just save the patient a CT angiogram and take them straight to the angio suite. And it was beneficial for those patients. They got there quicker, the costs were lower. Whether that's going to be the same in a place like Tanzania, I don't know, but there is some of that work that's been done before. And we know that, we used to do all of these strokes with general anesthesia, but we know that conscious sedation or moderate sedation does a pretty good job. And actually in my practice, I do most of our strokes with just moderate sedation with just a nurse administering medications, and it works really good. And similarly, there's been studies looking at single plane versus biplane, right? And so we know that you can do a stroke with just a single plane angio suite or angio machine, and you don't necessarily need to have the very, very expensive latest technology biplane. We can do it in a very easy way on stuff that's largely already available for other departments. And so we're doing this. We're trying to get this done as a what we call a Delphi survey. So we're trying to identify people who have, or providers who have been doing mechanical thrombectomy from large swaths of the world. Some people from the US, some people from Europe, but also people from Saharan Africa. There's a few people from Sub-Saharan Africa. Lots of people from Asia who have been doing this, who can maybe advise on what they've been making do it, right? And how they do it. And we're trying to do that survey. And in the final sort of stages of getting it ready. So hopefully that will come out maybe in the first round of those surveys will come out in sometime in January, actually. And then trying to identify the physicians most suited to performing mechanical thrombectomy and doing the training, which I always find, we sort of talked about this a second ago, that is very difficult. In some ways, it's very difficult to even pinpoint who does mechanical thrombectomy. So there's very few data available for the US. This is like a letter that I found in JAMA that looked at who's been doing that sort of work. And you can see mostly radiology up until 2015. And then in 2015, neurology and neurosurgery also started doing things. But again, with the lion's share being the radiologists. I don't know what the best person to do this system is. And we're trying to buddy up with the neurosurgeons, because I'm a neurosurgeon and I know them, but also with body radiologists in Dar es Salaam to see who would be the person who can pick this up first. And like I said, it's possible that it will be interventional radiology who will start doing these procedures just because they have the technical expertise. And then people from neurosurgery or neurology will have to just catch up. And if they want to participate in it, maybe they will at some later stage, but it may take much longer for them to get trained. And then obviously lots of people talk about cardiology, whether they would want to do that as well. They certainly have the skills, but cardiologists tend to be busy. And so oftentimes they just don't have the bandwidth to take on a new thing, which is not necessarily their forte. And then how to develop these sustainable models of education and training. And so that's very difficult. And we've just done the first sort of neurovascular course in Tanzania, where it was the first time I came out and tried to do some demo teaching and actual hands-on training on doing angiographies and simple endovascular procedures. But clearly, like coming out for a week and doing that for a week and then coming back again next year is not a sustainable solution. And so we're trying to figure out a way to do it in a better way. And actually here in Utah, there is a few people from the radiology department who go actually to Tanzania as well as part of what they call Road to IR, which is developed. It's a thing that's been like a brainchild of a few people on the East Coast here, but also some people from Tanzania who have effectively just gotten funding and organized multiple teams, not necessarily knowing each other, but they would come for a week or 2 weeks in a month. And having 12 or 15 different teams means that you have a sustained presence of somebody every month for a little bit, and they can provide the training and they provide some of the expertise. They can do some more challenging cases, but also just do the straightforward cases. And then the training follows on from that for the rest of the month. And then somebody new comes. And we're trying to sort of mimic that model and see whether we can organize that. This was the course that we went to in November, and that was great. I managed we managed. There's a gentleman here with me who's a Tanzanian-born interventional neurologist who works in Texas at the moment, who I came across as part of the research for this, and he's been there as well, and we're sort of trying to figure out how to do it together. But it's been very fruitful. We did lots of demos, we did actual cases. It was a very fruitful experiences, but the caveat is that, maybe I'll go in March, maybe I'll go after March. And so we're trying to now figure out that sustainable way of doing it. And then finally, when I was a resident in my department, a colleague of mine did this study called the Global Neurotrauma Outcome Study. I talked about it here many, many months ago, but it was a study looking at the outcomes for emergency surgery for TBI globally. It was probably the first prospective study like that. There's lots of studies looking at, like a lot of the global burden of disease studies that will do a retrospective analysis of published literature, but this was actually the first study that prospectively recruited patients and to see what's happened, if you get a head injury and you need an operation in various parts of the world. And we're trying to figure out how to do that for LVO as well and see if we can have that sort of prospective data available in a little bit. But that's a big project that we're only just sort of starting to think about. And obviously, this is a big team effort. So some of the people are here. So Diwas, who's a medical student, who's part of this center and always comes to these courses, he's been immensely helpful in participating in this project. Sarah Wen, one of our residents from neurosurgery, she has been also participating in this from the very beginning. But also other people. So Hal Mangat, who's one of those people who introduced me to the thing, has been very much involved. Fahim Sharif, who's the Tanzanian-born interventional neurologist, who's very much interested in trying to develop that. And then the guys from Mission Thrombectomy, who have been doing this for certainly longer than I have. Each one of them has a foot in a specific place, but they also have a slightly more global overview. And then some of the partners from my department, they've been very helpful in supporting this sort of work. But it's a very big effort, and it's a very much work in progress, or not even work in progress, but like the beginning of work that I'm really looking forward to. And I'd love to take everybody's, if anybody has any comments or opinions of what we're doing wrong, then I love to hear it, because it's always nicer to hear it in the beginning than afterwards. Thank you very much.
Questions. I just want to say, if any of the students need to run to class, you're welcome to leave. But comments? Yeah, Mary?
So thank you very much for the elaborative presentations, and you are welcome to Kenya. You have gone to Kibera. You can still come back to Kenya.
Yeah, I would love to.
So my question is on I agree with you. This brings I've lost 2 close people, and one we are running on Friday, got a stroke, went to the facility. He couldn't be transferred to Kenyatta within the span of 3 hours, and he died. My father-in-law got stroke and he died. So this brings a very emotive issue. And one of the things about your study is it's